Morning.
Good morning.
Good morning. This is Barbara Mead. Who's this?
Hi, Barbara. This is Martin, and Jenna's on the line as well.
Hi, Martin. Good morning, Jenna.
Good morning, Barb.
How's the snow for everybody?
Well, it is brisk.
I'm still not the biggest fan of snow. Almost 5 years living in this state, still don't like it.
We'll just give it a few more minutes for people to come back or come into the office, since it's probably they're driving slow. The roads are super slow today. So we'll just give it a few more minutes for people to give them the chance to come into the call. Good morning, Minnie. How's the snow over there in Dayton?
I wasn't really emotionally prepared.
I
I thought I wanted it, and then I remembered how slippery it is, and digging the car out, and yeah. Got Melissa on the line too.
Yeah, I saw that. Hi, Melissa.
Good morning.
Okay, so a few more minutes. More people are starting to dial in.
Shauna Banner's here from Lords.
Hi, Shauna.
Good morning.
Sandra's here from Yakima.
Hi, Sandra.
Hi.
Marcia from Garfield County.
Good morning, Marcia.
Liz Rice from Tri-State Community Health.
Good morning, Liz. Okay, so we'll give it 3 more minutes. We'll start at 8:05 just to give them a few more minutes if more people are going to be calling in. And it looks If you guys haven't signed in your name, either in the chat box or as a caller, please do so. That way we have a record of who attended this webinar, please.
Good morning.
Good morning.
This is Angela Bennett. How are you?
Good. How are you, Angela?
Good, thank you.
Okay, we'll just give it one more minute, and then we'll get started with the webinar.
Martine, this is Teresa from Police Medical also.
Hi, Teresa.
How are you?
Good. A little cold, but I'm good.
I know the feeling.
All right, guys. So let's get started. I don't know how long it'll take, how many questions you guys will have, but I want to welcome you guys on behalf of GCACH into your first quarter of year 2 of practice transformation. And I want to say, thank you all of you guys for all the hard work that you guys put into the first year. On my side, I saw a lot of, great success, a lot of good changes. The staff were motivated. They really enjoyed, this doing practice transformation. And the same with Jenna's sites. We've been hearing from her all the wonderful things that you guys have been doing. So applause to you guys. Now going into the second year, we updated some of the measures that we are requiring you guys to report to us. Hopefully it doesn't seem daunting to you guys, but Jenna and myself are here for you guys to ask questions. As your practice transformation navigators, always rely on us. If we don't have the answers to you guys, we'll come back, bring them back to Sam, and we'll get you some answers to your questions. So please, always reach out to us if you guys have any questions. So without any further ado, here are the 2020 practice transformation reporting updates for year 2. Jenna and myself have already presented this document to some of our sites, not all, but we have sent it out to all of our sites. So hopefully you guys have it somewhere. If not, we'll send it out again after today. And we'll send it out with the recording as well. And we'll post this recording in our website and also in our portal that you guys have access to. So you guys can go in there and take a look at the presentation. If you guys have any questions and say, hey, what did we talk about this question? So you guys, that recording will be up there for you guys to take a look at. On this document, can everybody see my screen, by the way?
Yes, I can see your screen.
Yes.
Okay, perfect. So here's the document. On here, there's 3 columns that you guys see. This first column, highlighted in blue, lists the milestones. It says milestone 2A1. This is empanelment status. And on this column, you guys will notice on the second row on here, where it says added. This question was added. It's a brand new question to the reporting portal and the workbook. So you guys will see that if a new question was added. And then also you guys will see other questions that will say modified. There are questions that were already there for year one. We just modified them just a little bit. And then we'll go over all those changes, as we go along the documents. And if at any point you guys have questions, you guys can either enter them into the chat box, or you can just, jump in and ask your questions as we're going through the questions. And then Wes just joined me, and Jenna's on the phone as well from our end. So they'll be able to jump in as well if you guys have any questions. And I don't know the answers to, but hopefully I'll know the answers to all of your questions. So we'll get started. On this first column, like I mentioned, this is the milestone. This is milestone 2A1, the empanelment status. This milestone stayed the same. You guys will still be required to empanel 95% of your patient population. And this was something that you guys were doing in 2019. And all the sites did it. Now we're saying that this will be a mandatory thing if you weren't doing it, but everybody was doing it, so we're not worried about this section. But just so you guys can be aware, this will be a mandatory thing for 2020. The second question on here that you guys will see, this is an added question to milestone 2A1, 1B. This question centers around the managed care organization patient rosters. This is something added, so this is blank because it wasn't in 2019, but for 2020, we are asking you guys to attest that you have reviewed your panel patients against the rosters of the managed care organizations, the MCOs, on a monthly basis. And then there will be some data requirements for this questions. So you guys will have to provide the number of patients according to the MCO rosters. And this only applies to primary care sites, since we know that hospitals don't get any rosters. I don't know if BH gets any rosters. I'm pretty sure they don't. Urgent care doesn't. The dental clinic that we're working with doesn't get them either. And then
Martine, do you want questions as we go along, or would you rather go through the presentation and have questions later?
Questions as we go along.
Okay, then this is Kevin from Pasco. I have a comment about this added one. I've heard people say in our organization that they have a tough time even getting the lists of people from the MCOs monthly. In other words, they reach out to a particular MCO, give us your list, and they'll get a partial list, or they can't get the list. So I'm just saying, it could be tough when we can't even get the list from the MCOs about who we're supposed to be contracted with. And as you know, many patients in Medicaid change month by month. So that's a challenging one. That's a real challenging one.
Yeah, so we're aware of that challenge. So what we're doing in our end is we are working with the MCOs to identify a workflow or a person that will be available, and be sending you guys the rosters directly to a contact person for your site, or somebody that's going to be responsible to create a login information to go into their portal and get the rosters from that portal. But we are working on that end, on our end, to get those rosters to you guys in a more, in a better fashion.
Thank you.
This is Wes. We've established an ongoing call with the MCOs, and this is one of the topical areas that we're discussing with them. So more to come.
So this is Sandra. So along those lines, will a member of the cohort be penalized if that's not worked out in the time of reporting?
Sandra, if you're struggling to get at that information, if you could pass on specifically which MCO you're having problems getting that data from, getting the rosters from, we'll try to work directly with them to get that resolved.
So just to be clear, so what you're saying, as long as you're aware that the site that you're working with is trying to work with the MCO to get that, they will not be penalized.
Correct.
All right, thanks.
And then also, we got a question for the members that, you guys are supposed to be reporting for the MCOs. Those are Medicaid patients. And then it would be either, we got the question of, do we want them on a monthly number or a total for the quarter? What do you think on this question, Jenna?
Those will be quarterly. I'm trying to respond in the chat box to questions as we go along too, just to help out. And so that will be quarterly for those numbers. So you'll just report them on the quarterly basis.
Okay, perfect. Okay, and then we'll go along. Any other questions around this MCO rosters?
This is Teresa. To clarify, this is only for Medicaid. We do not need to do our Kaiser or any of the others, correct?
Correct.
Okay, thank you.
I didn't even know Kaiser gave you guys rosters.
Hey, Wes, is that you?
Yeah, this is Wes.
Hi, Wes, this is Teresa. Yes, we've requested ours, and so yes, we've been getting our rosters. One thing is we're wanting to track our new patients and making sure they meet their care gaps, and so I'm getting a roster about quarterly from them.
That's fantastic. Good for you for going out and getting out that information.
So are you wanting me to report that also or not?
No. So the Medicaid transformation focuses specifically on, as the title indicates, Medicaid populations only.
Okay. Is there a contact person for us to be able to obtain that type of report? The person who shared that they're getting the report on a quarterly basis?
Should be the provider rep for the MCO.
Mm-hmm.
Are you talking about Kaiser or are you talking about Medicaid?
The Medicaid. So for the 4 MCOs that are in a region, they should have a rep. But we're working on it too, just to see, because sometimes they can be really slow to respond. So we're trying to figure out, what's the quickest way for them to be more proactive in this area.
So are you guys as the practice transformation navigators or as the ACH going to be that person to help connect? Because I think what also might happen is the reps from the MCOs will reach out to somebody and it is a completely random person that might not have anything to do with the practice transformation work. So are you going to help make those connections between the right folks from our organizations and from the MCOs?
Yes. Yeah, so we're trying to streamline this whole process and really get a point of contact for the practice transformation sites that will be responsible for those, and then also on the MCOs, and a person that will be responsible for getting you guys those rosters in a timely fashion.
Thank you.
Mm-hmm. And then for this question, the MCO rosters, if you guys have noticed on the reporting portal, these questions are already added for year 2. And there's a little table on here for this question where you guys will be able to enter those numbers for your patients.
Martin,
Moving on.
This is Teresa
go ahead.
again.
No, go ahead.
Ashley pulled it up. You can get your rosters online. We just pulled ours up, for Melina at least.
Yeah, they have portals, but some also send them out. So there's different ways that you can get them, but we're trying to figure out, what's easiest for each site. So, that's probably a thing that we can talk more one-on-one with either Jenna or myself, depending on, what site it is. But they do have portals where you guys can go in and create your login information and get those rosters out.
Thank you.
Mm-hmm. And then, so moving on to milestone 2A, this is the risk stratification methodology and types. This question is where we list all of the different options of how you guys can risk stratify your patients. For 2019, we're asking to risk stratify 75% of the 95% impaneled patients and provide care management services to at least 80% of those high-risk patients that are identified through the risk stratification. For 2020, we bumped those percentages up just a little bit. It's still impaneling 95% of your patients, but instead of risk stratifying 75%, we're asking you guys to risk stratify 85% of the 95% impaneled patients. Of the 85% that are risk stratified, we want you guys to provide care management services to at least 95% of those high-risk patients. Does that make sense?
Yeah, but so it's really, this is Kevin in Pasco, so it's really 95% of the high-risk patients, right?
Correct.
Not 95% of all the 85%.
No, 95% of the highest risk patients. So if you have 5, providing, care management to hopefully all of them, because there's not that many, but if you have more patients, say 20, 15, depending on the number of patients that are identified as high risk, then providing care management to 95% of that number of patients.
Martine, this is Michelle Sullivan. Should we be reporting then the number of patients that don't meet a risk level as opposed to just reporting those that do?
I would, yes.
Okay.
Because that will let us know. And on the workbook, on the how you guys are putting in your data for this section, there's, you have your highest risk, second, third, low and no risk. So you guys can put them into those risk stratums in there.
Okay. Thank you.
Yep, you're welcome. Any other questions around this?
This is Barb. I have a question about this language. It says the target is to achieve, etc. Does that mean that we have to hit that mark the first quarter, or to show progress after the first quarter?
Well, we would hope that you guys are hitting that mark already, since you guys have had a whole year of kind of, getting into this rhythm of, okay, let's look at our patient population. Let's risk stratify, our patients quarterly to see if anybody moved up, anybody moved down. So our hope is that you guys are meeting this mark by, first quarter.
Okay.
Moving on, milestone 2A2, question number 1, or 2A question 1. This one, 2019, please identify the data types that your practice uses to risk stratify. Select all that apply. For this question, for 2020, we are asking on the risk stratification types and methodologies that you guys use social determinants of health when you guys are risk stratifying your patients. So this will be something that will be mandatory for all of our sites, regardless of what measures you guys are using already to risk stratify your patients. We're just asking to add the social determinants into the risk stratification of the patients. Questions?
Hi, this is Laurel in Pasco. I would just like to ask, so is that meant to be for every patient of our impaneled patients to have a social determinant of health screening, or is that for high risk stratified, and is that to be achieved as we incrementally move across the year, or is that the expectation that we have it for quarter 1?
So for your first question, this would be applicable to all of your patients, regardless of high risk, status. This, will get a better gauge of your patients, seeing if they need housing, food, transportation, whatever their needs are, because we know that those have a big impact in their health. So we're just asking our sites to incorporate that into the risk stratification methodology. And for the other question, if you guys are already doing or tracking social determinants of health, we're hoping if you guys can to add it for the first quarter. If you guys aren't screening for social determinants of health currently, then this would be something that we can work on for the first quarter, get that implemented, and then see how we can work that into the risk stratification. And again, that's something that we can, Jenna and myself, can work with you guys individually.
Martin, this is Melissa. I have a question. How often are we required to give this survey or do the social determinants of health assessment or screening? Is it annually, or is there as long as we hit each patient? And then are there any specific requirements? I know that we talked about the Prepare tool, but our EHR already has a few of those built in for tracking purposes. So is there a requirement of anything that we need to hit under social determinants of health? How is that outlined?
We don't have any guidelines for that. We know that different organizations use different tools to get this data. As far as the screening, I would say at least once a year. If it depends on what policies you guys already have established around this for your organization, but I would say at least once a year. If not, twice a year, every 6 months, because things can change, in the snap of a finger. So it would really depend on how you guys would, want to do it and how it would fit into your daily workflows.
Thank you.
Okay, so moving on, milestone 2A, question number 2, 2019. Using the data types, your practice will provide a concise narrative describing the approach, methodology, or tools used to stratify patients by risk and how this information is recorded in the EHR. We have this questions for 2019, but now this will be a mandatory. We're not providing this narrative, but now it will be a mandatory thing to provide it in for this year. Just provide that narrative of how you guys are risk stratifying your patients and how that information is being recorded in your EHR. The other question that will be mandatory that is was already part of 2019 measures is use information to record the total number of patients in each risk stratum and the number of patients within the stratum that receive care management services during their reporting quarter. So this is kind of going back to your question that you asked earlier, Michelle. So this will be, again, mandatory, providing all those patient numbers, even if they're no risk or low risk, still providing those numbers. Questions? Okay. So this question is modified, milestone 2A3, opportunities for those at highest risk. This is question 1. This is a selection for this question. It says select 2 additional opportunities to enhance your care team to care for those at highest risk. And you guys have already made the selections for 2019. You guys can keep them the same, or if you guys have implemented new things, then of course, mark that you guys have added something new into this workflow. What we are asking for 2020 is that will be mandatory is to conduct a daily in-person or electronic team-based huddle within your sites. Questions? And this can be, quick 5-10 minute huddle just to kind of plan out the day and see what patients are coming in, if any patients are, miss or have any care gaps that you guys can address while they're coming in, diabetes screenings, blood pressures, whatever care gaps they have, kind of looking ahead into your day and kind of making a game plan. Okay, this is how we're gonna treat this patient, or these are the steps that we're gonna take to, close some of those care gaps that this patient has. Any questions around this?
Hi, Martina Secchi from Walla Walla. I'm assuming this works best in primary care clinics, but to overlay it within the hospital and urgent care, could it go with it just our daily rounding on units? Or I don't want to get too much in the weeds, but I'm trying to parse it out to what it looks like in non-clinic situations.
What do you think, Jenna?
Becky, that's a really good question, and we've had that come up with some of our sites that are systems. So absolutely, yes, that can be fulfilled during rounding. And I know we talked, I think it was at Lourdes in one of our meetings, like what would that look like on the weekends? And so the method that you use at the hospital level to do your rounding, maybe even if it's with like a hospitalist, just somehow that you're touching base of the patients that are either coming into your clinic as much as you can possibly know for urgent care, and then the patients that are on your unit in the hospital. So absolutely, great question.
Excellent, thank you.
Thank you, Jenna. Okay, any other questions? Okay, so moving on to milestone 2B1. This is bidirectional integration of behavioral health. Question number 2. You guys, for this question, you guys already, again, have your selections made on what evidence-based instruments or tools you guys are using to systematically assess your patients and monitor or adjust care. For 2020, we're asking you guys to provide us some data for those screening tools that you guys are using, just the percentage of patients that are screened with the tools that you guys have selected within your workbook. So if you guys have selected the PHQ-9, GAP-7, what any other assessments, then we're asking, the percentage of patients that were screened with a PHQ-9 or GAP-7. Questions? Okay. So moving on. This question is modified from 2019. This is, again, 2B1. Question number 11, identification and outreach to patients lost to follow-up. So for 2020, sites will follow up with patients after one no-show. Follow-up can be completed via phone call or mailed letter. There should be 3 attempts to contact the patient if follow-up is being completed via telephone. We're asking some data around this question. We're asking to provide us the percentage of patients lost to follow-up and those that received follow-up. So it'll just be a denominator and numerator that you guys will be providing. And the follow-up, we've had questions around this. What is the definition of a follow-up? That really depends on, again, the policies that you guys have in your site. What is a no-show? It's like a one time that they don't show up, second time, however you guys have it set up within your organization. But we are asking you guys to track, the number of patients that didn't come in, depending on, your policy, and then those that received follow-up either, by a letter or by telephone. Questions?
Martine, this is Barb. I've looked at this milestone several times and suddenly I'm confused about it. Is this milestone regarding outreach to follow-up specific to just the bidirectional integrated patients, or is it to all patients? What does it apply to?
I'm going to need some help here, Jenna. What do you think?
You're good. You're good. This one's all patients. So I can see how that could be confusing. We never even thought of that because it's in 2B1, which is bidirectional integration, but this is one that applies to all patients. And so we're actually making some updates to the workbook. I know we sent that out last week, and then per usual, we found some stuff that we need to change. So we can make sure that that's clear in the language in the workbook too.
This is Kevin in Pasco, and without sounding too negative, that's a huge bite to be able to say we're going to go on the bidirectional behavioral health primary care integration patients and follow those up and keep track of who's following up and who's lost to follow up. But to say we're going to do that to all of our patients is a huge quantum leap.
This is Mandy from Kittitas, and I agree. That's exactly what I was thinking. Like, wow, high-risk patients even, too, that we've said, they're at high risk, or even somehow weeded down to, like, those that have, other issues or we're care managing. But all patients that are no-shows is a big burden.
So we reviewed this one with our PTW and our board, and I'm thinking, Dr. Taylor, specifically when we met with Lord for the clinics, I thought there was already a process in place that when a patient no-shows, they're automatically generated a letter, which would
we do. That's right. We have no-show letters, but we don't keep track of who comes back in and who's lost and who doesn't come back.
So what we're asking for here is you would give us, and Mandy, I can talk to you about KVH as well after this, but you would give us the denominator, which would be your no-shows, and then the number that we're followed up with would be the number of no-show letters that were sent out.
Okay, I see. So we don't actually have to keep track then of the patients that actually made it back in or the patients that were lost to follow up. Just that we reached out to them, we sent them their no-show letters, and those who no-showed, how many were sent no-show letters? Is that correct?
Correct. And so we left like a little caveat in here for the ones who want to receive follow-up via phone. And so we added the letter because we understood that was kind of the general theme for our region, is that most folks have, if a patient no-shows, they get a no-show letter automatically generated and sent out. But we recognize that there's also more like pertinent things that might need to happen, like you need a phone call for this no-show. And so we wanted to leave the autonomy up to those sites to be able to contact via phone. So the intent for this milestone is just to know who no-showed and that they got followed up with. And then when we're meeting with our sites, me and Martine, we can then talk about like, okay, so what would be a next step? But just to fulfill the milestone, all you have to do is tell us who no-showed and who got followed up.
That makes more sense. I was looking at the 3 attempts to call all the no-shows, and that was what was feeling very burdensome.
And Mandy, that's where we started, and we got a good amount of feedback on that. So.
Okay. Thank you.
You're welcome.
Okay. Any other questions before I move on? Okay. So still on milestone 2B1 bidirectional integration. This is question 13. For 2019, we're asking to tell us what measures you will use to assess the integration of behavioral health and the impact of behavioral health services on your patient population. For 2020, we're asking the same question, just we're adding a data component to it. This is a fill-in-the-blank measure track. So you guys will have to kind of prove it to us or show us that, hey, the patients that are receiving integrated services are, what are they? Are they getting better? Are they getting worse? Are they staying the same? So we're adding that data component onto this question. Questions?
This is Kendra. How does that work for behavioral health agencies? Should we just be picking a tool that we already use, or just because our answer for that one is that we're a behavioral health agency? So we don't have.
Are you guys?
Go ahead, Martine.
No, sorry, go ahead.
For speaking for like Catholic Charities, specifically, like you could give the reports you send me would satisfy this measure. So the number of patients that receive the PAM, the number, whatever it is that you said, this is how we're going to prove that what we're doing is working. So whatever behavioral health element you chose to focus on within Catholic Charities is working, you would just upload a report that shows that.
Okay. Sounds good. Thanks.
Okay.
Any other questions? Okay. So moving on, this question is modified, still on 2B1, question 14. We're asking, how have you increased your practice capacity to implement this program in the past quarter? For 2019, it was just a selection. For 2020, it's still the same. We're just adding a mandatory MAT training or MAT referral source identified, or referral to the Opioid Resource Network, the ORN. There's one in Bend, Franklin, and Walla Walla counties. There's one in Yakima, and there's another one in Garfield, I want to say, Stoughton and Columbia County. They have their own ORN. Or if you have, MAT providers within your organization, then, this would fulfill that milestone. For the most part, I want to say almost everybody has, either a MAT referral source identified, or they have, a provider on site, or, now we're providing this option as well to the Opioid Resource Network. If you guys don't know what it is, or want more information on this resource, please let us know, and we can connect you with the person that's responsible for running the Opioid Resource Network in the different counties. Questions? Okay. Milestone 2B2, this is self-management support. Questions 2 and 3. Questions 2 and 3 for 2019 list what high-risk conditions, at least 3, are the focus for self-management support in your practice, and how many patients in the practice have that condition. Question number 3, how many patients receive training in managing their disease or condition this quarter? For 2020, we're still asking the same questions, but we're asking that a minimum of 10% of the patients with those specific conditions that you guys have selected received intervention, and this will be mandatory for 2020. Say, 20 or 10, 20 patients, have, diabetes, then 10% of those 20 patients will need to get self-management support for their diabetes, and any other conditions that you guys have selected. Any questions? Okay. Moving on. This question is modified for milestone 2B2, question number 5. What approach are you using to assist patients in assessing their need for self-management? For this question is asking to select what you guys are already doing. For 2020, we're adding the selection for initiated process for referral to health homes. For those patients that qualify, at least making that referral, initiating that referral process. And then that will just be a selection on there. If you guys, are providing those referrals, then you guys would make this selection.
What do you mean by health homes? Do you mean like the MCO's health home, their care management process, or do you mean like that, we're their home for health in the clinic because we're their primary care and their care team?
Yeah, no, so this would be on the MCO's health home. So the programs that they have for those, the care management.
Hi, so this is Laurel from Pasco, and could we get more information about health homes? I'm sorry, it sounds like I'm not the only one who doesn't know about this.
Yeah.
I mean, I've heard of them, but I'm just not real familiar with the practice actually of referring to them.
Oh, okay. Yeah, we can definitely send out some information out.
Yeah.
Okay. Milestone 2B2, question number 10. What measures are you using to track the impact of support for self-management on care processes, health outcomes, or costs for the conditions that you identified? Again, a data component. Uploading reports on selected measures will be required in 2020. For the selected measures, that you guys have selected for the self-management support. Questions? Okay. Milestone 2B3, medication management, question number 2. This one should be fairly easy for you guys. What comprehensive medication management services does your practice provide? This should include medication reconciliation and additional services. For 2020, medication reconciliation will be mandatory. And again, I want to say at least 100% of our sites for you guys, Cohort 1, are doing medication reconciliation. But just in case you guys aren't, this will be something that will be mandatory for 2020. Questions? Okay. Milestone 2B3, question number 3, how does your practice engage pharmacists as part of the care team? For 2020, engaging pharmacists will be mandatory in 2020, either if there's some type of collaboration, if they're integrated, there's a contract, or you guys are using telepharmacy. And this will be, a requirement for 2020 to engage the pharmacist as part of the care team for the patients. Questions? Okay. Milestone 2B3, question number 7. Does your practice provide collaborative drug therapy management? So this one kind of ties back to the engaging the pharmacist. If you guys have a contract or staff a pharmacist in your site or within your organization, a collaborative drug therapy management will be mandatory for this year. And the collaborative drug therapy management is basically an agreement between the patient's provider and the pharmacist, where the pharmacist has more of a say on the medications that, if he notices that the medication that the doctor prescribed to the patient is really not for that patient, then that pharmacist is able to switch him to, other drugs or other medications that are more beneficial to that patient. And again, this will take some load off the provider and put it more on the pharmacist's plate.
So is this again for the entire population of patients, like in the clinic and the hospital, or is this a subset of a population?
For the entire population.
Martine, are you saying that we have to have an agreement with every pharmacy that we prescribe to? Or that patients get prescriptions filled?
What do you think, Jenna?
I can jump in right here. So I'll kind of start at the 2B3 question 3. So engaging pharmacists. So this is just for anybody. We just want a pharmacist to be engaged as a part of the care team. We recognize some people don't have an in-house pharmacist. So this could be like something as simple as having an agreement with the Safeway that most of your patients go to. So that satisfies that 2B3 question 3. But for 2B3 question 7, providing collaborative drug therapy management, we're looking for those of you who have like pharmacies on site that are contracted or staffed. So they're a part of your organization that you do collaborative drug therapy management. And KVH has, Kittitas Valley Healthcare has an excellent example of what this looks like. Does that help?
So you're saying that if you don't have contracted or staffed pharmacists on site, then this part wouldn't apply to you?
Correct. So if you don't have a pharmacy on site, and you just rely on the Safeway or the Fred Meyer, then this doing collaborative drug therapy management would not apply.
Yeah, and this is Kittitas. We do have an excellent example of it, but it's not on all of our patients. It's only on diabetes patients. So as far as a pharmacist review for each patient, that I think there will be a staffing challenge with that. And we've been fortunate that we have a lot of pharmacy interns that come through that do a lot of our med reconciliation and work with this, but I do see this one as potentially being a staffing challenge. Good work.
And so, Mandy, yeah, it's keep in mind that we don't have like a threshold for this question or anything like that. There's no 60% of your patients need to be participating in collaborative drug therapy management or anything like that. So if you're starting CDTM with your chronic care management population, then that's great. That will fulfill the milestone. And as we hope to, you know, expand that as staffing and bandwidth allows. But if you start with a small group and you're still doing CDTM, you get credit for this milestone.
Okay, thank you.
You're welcome.
Any other questions before we move on? Okay. Milestone 3A1, question number 3. This is something that, a new question that's added for 2020. So this is for our clinic sites. They will be responsible to report on their third next available appointment for the following types: acute visits, adult well visits, well-child checks, and new patient visits. Questions?
I don't know what that means, third next available. Am I slow?
Basically, what's your, you know, your third available appointment for, say, you know, they need to be in for a follow-up, or they're a new patient and they're trying to get in right away. So it's just a way to, and this measures your availability, or your what's the word I'm looking for? Access. Your access to the clinic and to the providers.
Okay, I just never thought about it in that way of third next available. For a behavioral health agency, new patient visits we could do, but how do you do like a follow-up, because it will depend on the clinician?
Yeah, and this is only for primary care. So if you're a behavioral, it wouldn't apply to you guys.
This is Mandy at Kittitas, and yep, third available is pretty standard to us. I don't know if this is true. I just wanted to mention this to you all, that I think we have had a challenge in the past at pulling third available by appointment type, though, in some cases. I think we do have it for new patient, and but the rest I think we've had a hard time sorting out. So that just may be a challenge for some folks this year.
Okay.
So
and
sorry.
Go ahead, sorry.
This is Teresa from Palouse, and we have been doing that for years, keeping track of next third available appointment. But what she's saying is, for example, a well child, we track what's the next available, what's the next physical, and what's the next 30-minute slot. So can we say if a well child takes 30 minutes and if a new patient takes 30 minutes, can we just put those into the 30-minute slot?
I think that should be fine. This is Jenna.
Okay.
Hey, Jenna, this is Laurel. What's the frequency of that reporting?
This is quarterly, so you'll just let us know on average what your third next available each quarter. And so I know I've mentioned to Lourdes, but just so everybody on the call knows the intent behind this milestone, we had a large amount of discussion about patient assignment with the MCOs and how sometimes patients get assigned, but there's not the access on the organization's behalf to see those patients. So this is for us to be able to report back up to the state and say, okay, we not only have the variability between MCO assignment and what organizations and sites think they have, but we also know that if you're assigning patients to these sites, they may or may not have the access, so we can tell you their third next available. If that makes sense.
Any other questions? Okay, so moving on. This question's added again to milestone 3.1. This will be question number 5, and this is just something that, you guys will be able to type in. We're just asking what workforce or training does your organization need in order to provide patient-centered care. More community health workers, more behavioral health peer specialists, ARMP, pharmacists, more providers, whatever workforce needs, then, we would want to know those needs to see if we can, as an ACH, kind of tackle some of those barriers. Milestone 4A1, this one is modified. This is conducting a monthly practice-based survey of their patients. Each quarter, the sites will be expected to show an increase in the percentage of patients that received surveys. Questions?
Our team?
Uh-huh.
This is Deb Watson. What if you're already sending surveys to every patient?
Then
or
you
you
guys
have
are,
a threshold that you're sending patients?
if you guys, there are some thresholds as, as far as phone surveys. If you guys are doing it through a third person kind of, Crossroads, I know they have a threshold for those. So we are aware of that. So if you guys are meeting those thresholds, or if you guys are giving them to all of your patients, on a quarterly basis, then you guys are good in this area. But if you guys aren't, then this is something that, we can work towards.
Okay.
Yeah, and we have like a contracted number that we have with our third party. I'm not sure what the cost would be to us to change our contract to survey all patients.
Yeah.
I mean, we're surveying like 400 a month anyway.
Yeah. What do you think, Jenna, on this question?
So we had that feedback as well, Mandy, when we were putting this together, because we do have sites that have exactly what you do. So they work with Crossroads, and Crossroads gives them X number, and then it would be, I don't know how much add the number. So that's the case
with them, and I just, that's concerning to me, and I'm not sure what the benefit is.
If that's the case, then you wouldn't be expected to have the increase. So for our organizations that you contract for this is the number you get. You're getting statistically significant data, like 400 is a great number of surveys that you get returned back. Then you don't have to worry about that. But if you're one of the sites that maybe you do your own survey or you're not contracted and wouldn't have to pay for more, then we expect to see the increase. So this is just going to come down to me and Martine knowing our sites.
Okay, thank you.
Okay. Questions? Any other questions? Almost done, guys. I know we have an hour, so we have 5 minutes. This is modified again, milestone 482, patient-centered experience focusing on shared decision-making. Question number 3, for 2020, we're asking each quarter the sites will be expected to show an increase in the percentage of patients that receive shared decision-making documents. Questions? Okay. Moving on to milestone 5A1, the quality improvement team. For this question, it's already being asked, or what's already being asked in 2019. For 2020, we are asking that you guys having a minimum one internal monthly QI team for 2020. And again, a lot of you guys have your QI teams in place already and are already meeting this milestone. So this should be fairly easy for you guys. But if you guys aren't, then, this is to get you in that rhythm. Okay, every month, let's sit down and look at what we can do quality improvement on. Looking into the surveys, how we can incorporate, the patient voice into quality improvement activities that we plan on conducting on our sites. Focusing on that. So at least one monthly QI team meeting will be mandatory for 2020. Milestone 5A2, question number 2. This is something that you guys already already did for 2019, looking at your clinical quality metrics for your entire practice site on a regular basis. Or 2020, we are asking that you guys review this clinical quality metrics weekly or monthly at least, and this will be something mandatory for 2020. And again, that's just to look at, what care gaps do we have, or, are we not doing as many diabetes screenings as we should be doing, things like that.
I have a quick question about this. This is Mandy. And maybe we'll probably work this out with Jenna, but just to ask. So our challenge last year was that our EHR couldn't separate it by practice or clinician. And so our goal this year is to work on building our own where we can do that, but that will be a challenging process, and it may be that we have to focus on one metric at a time, even if it's, hand calculating it.
Right.
Would that then meet this, or?
I would say yes, but, letting us know that you guys are working towards that goal of having this information by site and by provider.
Yeah.
Yeah,
I mean,
but,
that's one of our targets this year. It's just we're having to build it from scratch now. So,
yeah.
I mean, yeah. So,
yeah,
okay, we'll work with you on it.
Yeah.
Okay.
Perfect. And then milestone 582, question number 4. We're just asking that you guys upload those reports, your clinical quality metrics that you guys are focusing on for the year. And you guys have, again, already are doing this. So we're just asking that mandatory to upload those report examples of your clinical quality metrics. And then this one, milestone 583, question number 1. This is something that we do already. If now we meet more than once monthly, but we're asking minimal monthly meetings with practice transformation navigators, which that will be myself and Jenna. And we are already doing this with our sites. Our goal is to meet with them at least once a month, either in person or through the phone, or more if needed. Milestone 6A1, care coordination across the medical neighborhood. For 2019, we were working with the MCOs to get you guys connected with Collective Medical or direct secure messaging. For 2020, it will be mandatory that you guys will be using Collective Medical. And we are aware that some sites might still not have it, but we are working towards that goal. So this will be something mandatory for 2020, that you guys are using the Collective Medical platform to do your follow-ups after patients are discharged from the ED or inpatients, and this will be mandatory. Questions?
Can you clarify the difference between Collective Medical and direct secure messaging?
Yeah, so Collective Medical, this is the EDI system that all the hospitals have in our state, Oregon, Idaho. So when one of your patients presents themselves to the ED or are admitted into the hospital, the PCP of that patient will be notified through the Collective Medical platform, letting them know, hey, your patient has been admitted, or they're at the ER. And then they're able to see care plans on there, what's been prescribed on this platform. Direct secure messaging works more like secure email, where you're able to send, like private information through there. So it works more like an email. Was that clear?
Yes.
Okay. Milestone 6A1, question 3. This is an attestation. Please attest that your practice is using One Health Port, mandatory by Q2. This is a new question that will be added in 2020. And One Health Port, we don't mean the insurance, where you guys are able to check the insurance of your patients. this One Health Port is the data repository for the state that providers are able to input patient data into it. Where if you have access to One Health Port, you're able to log in and see your patient's past medical history on here. Right now, they have a 1-year view-only subscription that is free of charge for 1 year, and then after 1 year, then if you guys want to continue, then there would be a fee for continuing on One Health Port, and they have different tiers of how much they would be charging depending on the revenue of your organization. So it's not too pricey, but they have the 1 year free subscription right now that you guys can ask myself or Jenna, and we can send you guys this information.
What if there's a different HIE that we can access, like through Cerner, we have access to this thing called Commonwealth that I think does search. It might search One Health Port's HIE too. I'm not sure, but would that count?
What do you think, Jenna?
We'll have to take that one back to Sam. Mandy, you said it's called Commonwealth.
Yeah, so like just recently, right, we've had this huge influx of patients from family health care in Ellensburg because they've changed their practice model. And when we've turned on Commonwealth, we're able to search for, and I do think it's connected to the One Health Port HIE is my understanding, but we were able to pull in their records and look at them within our EHR through that, and it's been part of promoting interoperability is what they're doing with Cerner on that. And so I think the intent and the functionality is the same. So to me it makes sense, but we can dig into that more later.
Okay. Well, I'll just queue up an email, and so we can get back to you on that one.
Okay.
This is Deb. Can someone explain kind of the reasoning behind this One Health Port access?
Hey, Deb, this is Jenna. Basically, the reasoning is kind of what Dr. Taylor mentioned before, like certain MCO patients have the ability to change providers, or not providers, insurances or MCOs month to month. So we just want to make sure that our sites are at least using One Health Port's functionality for that. I know many sites on the clinic side, they use One Health Port to check and see if a patient is still insured under a particular MCO before they have the patient visit, so they can bill the right MCO for it. So that's kind of the basic level of what we want people to use it for.
Okay.
Does that help?
Oh, and this is Mandy. So I think there might be some EHRs that have an interface with it already too, because I was thinking of the One Health Port as far as the health information exchange for care information, not for like a continuity of care document, a CCD, not for the insurance verification. So there are a couple reasons why people you might want to clarify too.
Okay.
Well, this is Deb, and my little understanding is that it's not a very friendly site. So
we can follow up with that.
Yeah, if it's just used for insurance, that's maybe not a bad thing, but if it's used for much else, I don't know how good it is. But like I said, I don't use it much, so.
Okay. Moving on to Milestone 6A1. This is a modified question from 2019. This is question number 4. And this changed a little. So you guys will see on here for 2020, all 3 options are required for reporting for 2020. If you guys see on here, some say clinic, others will say hospital for the same 6A1, selection A, selection A. This change on the hospital side, so 6A1, selection A for the hospital, identify patients without a PCP and make a referral. This was, for 2019, hospitals were required to do follow-up contact within 1 week of ED discharge for the hospital patients, but now we're changing that to hospitals have to identify patients that don't have a PCP and make a referral to a PCP for the hospital. For selection B, the clinic, follow-up contact within 72 hours of inpatient discharge. Each quarter, the sites will be expected to show an increase in the percentage of patients that receive inpatient follow-up calls, with an ultimate goal of achieving 95% of follow-up calls for patients for inpatient discharge. And the same for selection A, 6A1, follow-up contact within 1 week of ED discharge. The goal is to achieve 95% as well on this. For the clinics, selection 6A1, selection B for the hospital, again, identify patients without a PCP and make a referral. Selection C, care compacts / agreements, and not care compacts or collaborative agreements with at least 2 groups of high volume specialists. So depending if your site's a hospital or a clinic, then you guys will see what you guys will need to be tracking and reporting. But remember that all 3 options are required, regardless of if you're a hospital, dental clinic, primary care, dental, behavioral health. All 3 options are required for 2020. Questions?
Martin, this is Melissa. I have a question about the ED follow-ups. I just need clarification on if the patients that are coming into our ED are not our patients in the clinic setting, because we have a rural hospital and then rural clinics. Are we still required to do the ED follow-up calls on patients that are discharged from our emergency room that are not part of our clinic setting, that are not established with us?
I would have to take that to Sam and ask her that, unless you have something, Jenna. Do you know?
Can you repeat the question? I just want to make sure I'm answering it right.
Yeah, so we have multiple patients that are not established with us that utilize our ED because there's another ED in the area that just has a higher volume, so they'll come out here and utilize our ED, but they're not established with us in the clinic. And so right now we're calling every single patient back that has been discharged from our emergency room, even if they aren't part of our clinic, and following up. And so my question is, and a lot of the patients have an established PCP outside of us. So if a patient is being discharged from our emergency room, but is not established with one of our PCPs in our clinics, are we following up on that and calling them?
So that it exactly applies with the 6A1 selection A for the hospital. So the goal would be for you to do exactly what you're doing now, identify patients who don't have a PCP and make a referral. So we left that pretty vague on purpose because we wanted to give you guys some autonomy on how it was best to do that with your staffing and workflows. So it kind of sounds like that's what you're doing right now, and maybe a little bit more with following up with every single person who leaves the ED from the hospital. Am I interpreting that right?
Yes, you are.
Okay, so does that make sense then what the hospital expectation would be?
So if the patient is, and I'm sorry to everybody else out there, I just want to make sure I'm very clear. If a patient is established with a primary care provider that's somewhere else, and they come and utilize our ED, and our ED, whoever's admitting them, we can't make a referral if they already have a PCP elsewhere. So would that negate that one person, or?
Yes. So if they already have a PCP, you wouldn't need to make a referral. It would be their primary care provider's responsibility to follow up with them. But for your patients, for patients that come in that don't have a PCP, you can make a referral to your clinic. And so if it's the clinic side, then they would be following up with their assigned patients within 1 week of ED discharge.
Okay, that helps a lot. Thank you so much.
You're welcome.
Thank you, Jenna.
Welcome.
All right, last question or last addition to 2020. This is milestone 781, participation in the learning collaborative. For 2019, we were requiring you guys to attend 4 learning collaboratives and 4 leadership council meetings each year. We have more than 4, so you guys had different options to choose from and attend. For 2020, we are asking, there will be mandatory learning collaboratives on building, training, shared care plans, shared decision-making aids, and self-management tools. These 4 learning collaboratives will be mandatory, but that doesn't mean that you guys can attend more than 4. These are just the ones that will be required to have some participation from at least one of your staff members from each site that we are working with, to be present, or if not in person, through the phone, and be participating in these learning collaboratives throughout 2020. And some invites have already been sent out for some learning collaboratives. They should have been coming by email. Diane Halo sent them out. If you guys don't have them, please let us know, and then we can forward the invites to you guys. But these are the 2020 changes. If you guys have more questions or more concerns, please reach out to Jenna or myself, and we can help you guys with your questions or any concerns that you guys have. But as of now, these are the 2020 additional changes or modifications that we have made to the reporting workbook, and you guys should see this changes reflect in the reporting portal as well. Any other questions before we go?
Yeah, Martin, this is Minnie Smith. When those invites go out for the learning, will they be labeled mandatory or optional so we know which ones we need to really focus on?
I'm not sure, but that's a good point, that we can add that onto the invite. That way you guys are aware.
Thank you.
Yeah. If there's no other questions, thank you guys for taking your morning and listening to myself and Jenna talk for like the past hour. And again, if you guys have questions, please feel to reach out to us. And that's it for today, guys. Thank you, guys.
Thank you.
All right, see ya.
Bye.
Have a good day.
Thanks, Martine.
Bye.